This patient in particular highlights one of the important challenges that we see. Here is somebody who came to see me after receiving 4 lines of therapy, and at that point, shortly before going to hospice care, we sequenced and found a 12 base pair insertion in her too. And then she ended up getting about a good 1 year worth of response to eratinib and a phase one, and as part of a phase one study, and lived for additional 1 year. And this person would have probably lived a few more months, but for the sequencing. So this really shows that it's never too late to do sequencing or identifying the molecular profile if it has not been done, but then doing it earlier is much, much better. So I thought for the purpose of discussion and personalizing therapy, there were only a couple of issues that are important, and I broke it down into 4 major stages. One is identifying molecular targets when we can find. Second is how do we cope up and incorporate the new generation TKIs and as they're coming along, and is A followed by B? Is it as good as just doing B first, just because the median progression-free survival is a little bit better, or we should get the maximum from each one and move on? And the sequence of these therapies is becoming more and more an issue. And then, of course, the big elephant in the room is immunotherapy, and how do you tailor it? Are we now going to see a plateau in terms of outcomes with checkpoint inhibitors, and how do we personalize immunotherapy? What exactly is happening in individual tumors, and how do you tailor that? And for way too long, our discussions have centered around advanced non-small cell lung cancer. But I think for the first time, we'll begin to see some improvements, some advances in the early stage disease. And there are many challenges there. And let's not forget that nearly half of our patients present with early and locally advanced disease. How can we optimize this? Here, the returns are much bigger. We are going for the cure, and how can we optimize this? So I just thought I'd highlight those issues as we go along. And this is a little bit dated. Nobody needs to be told how to do next generation sequencing. But the point of the slide is that there are many steps involved in this. While those things happen in the background, and this needs to be optimized in a way that we can do. And there's another reason I put this slide. We have been very good in talking or doing limited gene panel testing, and we argue about what is the utility of doing 200 genes versus 4 genes versus 440 genes. But in the ideal world, I would argue that we should do whole genome and transcriptome analysis in every patient with a matched normal tissue. You may say, wait a minute, who can afford this? How can we do this? And I would only point out the only one word, one name that comes to my mind is my good friend and colleague Lucas Wortman. I'm sure many of you have read his story in New York Times, and he is, in fact, I saw him 2 days ago in our division meeting. This is a guy who had developed leukemia when he was a medical student, ended up getting relapsed acute lymphocytic leukemia, and turned out to have exhausted all therapies, progressed following 2 bone marrow transplantation. And in fact, he was the second whole genome ever sequenced in the country or the world. By that time, we had just sequenced the first whole genome of an acute myeloid leukemia. His whole genome sequencing did not reveal any targets to go after. What really revealed the target was a transcriptome sequencing, which showed an 800-fold increase in FLT3, and he ended up getting sunitinib, which is a drug you wouldn't think of using in acute lymphocytic leukemia, and within 12 days, he went into remission. And no amount of cytotoxic could put that into remission, and then ended up getting consolidated bone marrow transplant. He's doing quite well, suffering through some GVHD reaction, but now he's living, now it's more than 7 years after that episode, and he wouldn't have had a chance of living beyond a few months. So his case would argue that whole genome itself may not give you this transcriptome. And we can talk about this later on in the session. And one thing is that we have not harnessed the power of whole transcriptome sequencing, even in the discovery space, because in TCGA, for example, when we did the lung cancer genomic sequencing, we had, at that time it was the right decision. We really went ahead with the peripheral blood for germline analysis because it was too painful to get normal lung tissue. And but then later on, it turned out to be, in a way, a bit of a problem for transcriptome analysis because we don't have matched normal except in a small number. So we have not really understood the whole transcriptome level, the changes. And if any, even though it's an anecdotal case, Lucas Wortman's story would tell you that there is much to be learned in the transcriptome space. And we see that number of times the DNA sequencing does not reveal things. So it is not, this audience does not need education. The targeted therapy is good. Here is a LCMC data. If you have targeted, some alteration and you get targeted therapy, you do better than if you don't have a targeted gene panel. This slide shows the weakness of, the clinical practice. In fact, current smokers do have targetable alterations. In the past, restricting this to never smokers was a norm, but now no longer it's considered to be appropriate. So it really, it is. The other challenge that's coming along is that now we find all kinds of variations. We don't know what to do. There are times you see a kinase domain mutation in a known gene that is known to be oncogenic, and this is amino acid changing alteration that Polyphen and others would tell you it's damaging alteration. But how do you treat this patient? What kind of information? It's hard enough to do a trial for MET exon 14 splice mutation. These are very one-off of these rare alterations. It's hard, and we and others are developing a number of these sites where we put data in the real time to see whether we can find these alterations that we can learn about this as we go along. The other thing is that we have shown that the whole we can do the tumor mutation burden based on the limited gene panel. We don't need a whole exome. This is a nice study from Foundation Medicine showing a perfect correlation in mutation burden whether you do the whole exome or the 200 gene panel. So showing that they are very useful. Of course, we can do this in the peripheral blood. With current technology, you can only do a limited gene panel. I think it's going to be very hard in the foreseeable future, even as far as I can say. I can think of doing a whole exome analysis using peripheral blood. You can do it, but it's mightily expensive. It's just not going to be feasible. The exosome based sequencing is of some interest, and I think several groups are trying to push that forward, and you could do that. Pleural fluid is certainly something to do. CSF is another area that remains vastly underexplored, as you know, at least the early studies from ours, which is going to be published, and others show that a third of these mutations are private in the CNS, and even a peripheral blood may not really tell you that. And I think it's certainly something we'll be looking at body fluids for this analysis. So that's something we should be talking about as we go along. So the genomic space, I would make 2 points. You can say that cynics would argue that we have learned all we can from genomic analysis, but I can say that there is some truth in that statement with regard to low-hanging fruits, but there are a lot of subtle things we have not really understood, rare alterations, coexistent alterations, tumor evolution as we go along, transcriptomic changes. The whole area of methylation remains grossly understudied, and I think those things need to be studied. Sounds like the pace that the clock is going. My talk would take 2 hours, but I'll cut short soon. And we also have done specifically one thing that is not very appropriate in today's age. In the olden days, when we did the genomic sequencing, we took patients or the tumors that had 60% cellularity, and we excluded anything that had more than 30%, 20% necrosis or 30%, infiltrating cells. And those are precisely the tumors of great interest today. And nowadays, the technology has moved on, and a lot of us are doing single cell sequencing where we try to identify various compartments and really get this at greater clarity. And that we need to understand. In fact, the tumor microenvironment in lung cancer is as varied as genomic alterations. You can have varying combinations of dendritic cells, Tregs, and others in non-small cell and small cell. And in fact, a very nice paper published from Miriam Mirad's group in Cell early this year is a great paper. I would encourage you to look at this, and I think it's really a model to do other studies. And I think we'll learn a lot more by studying those things in the coming years. And of course, moving on to the second phase, coming up with how do you sequence agents? And Ram can talk more eloquently about this than I can. It's nice work here showing that osimertinib superior to the standard of care and showing a nice improvement in progression-free survival. Does this mean that osimertinib should be the new standard of care? And similarly, I won't go into the details with this. As many of you know, it's extremely well tolerated. Similar problem we have with ALK. It's a good problem to have. Alectinib is superior to quizartinib in both the studies, the Japanese and the US study as well. So that's a challenge you have to deal with as we go along. How do you sequence this agent? Fine to start off with osimertinib or alectinib, but what do you do when they progress? And do we have a good strategy for those patients? And then in the next minute or two, Ram, if I can take an extra minute or two. And so immunoediting, now I won't take you through this. And now we have a number of drugs in the second line space, no issue. there. And the frontline space, PD-L1 positive, getting pembrolizumab is a non-controversial thing. But the real thing is that do we really combine them with chemotherapy? And I'm not so sure about it at the moment until we have randomized phase 3 data. But certainly, if these data hold up, then this really would argue that you don't even need to do PD-L1 testing. You can give it to pretty much everybody, this combination. And so this combination of chemotherapy and checkpoint inhibitors is something that we'll be dealing with. And we have not seen that impressive data so far, at least in my opinion, Nivo-EP combination in non-small cell lung cancer, and I'll argue even in small cell lung cancer. I know many of you may quibble with that. And in the last half a minute or so, I want to highlight a couple of things. Specific, stage 3 non-small cell lung cancer, durvalumab shows improved progression-free survival. Does it mean we should use it? The results are very impressive. You can drive a truck through the curves, you would argue. But then what really matters, in my opinion, is overall survival. But this is something that remains to be seen. If it is, that changes, in my opinion, big time. Biomarkers, an area of great progress. PD-L1 testing is a good but not a great biomarker. Add that to tumor mutation burden, that may improve this a little bit better. But I think really what the challenge is not so much who should get PD-L1 inhibitor or PD-1 inhibitors. How do you select tumors or patients for these various combination therapies? In an unselected group of patients, they may not do so well as we have seen in the early part of these trials with a number of these agents. So we got to be much smarter at selecting which group for what. And then we'll talk tomorrow about using neoantigens, which are really antigens that are private, and customizing vaccine-based therapy that's truly individualized therapy. This is a single-cell sequencing paper from Maria Murad. I talked about how they can be very different, and another thing that we will see. In the early stage non-small cell lung cancer, we really have to identify patients who would relapse. One way to look at the tumor mutations and evolution, Charlie Swanton published this paper that subclonal copy number alterations matter a lot. These things need to be confirmed. More importantly, we can find the cell-free DNA in early stage lung cancer. We can customize it based on tumor genomic profile, and that kind of analysis to identify those early relapses and customizing adjuvant therapy is another way to actually personalize therapy as we go along. There are different ways these cells, these cell-free DNA decreases and increases months and sometimes few years before therapy. So finally, I think we need to resolve how to do this sequencing in the clinic, how broad can be, how deep can be, and second is how to grapple with the issue of selecting targeted therapies. And then more importantly, the immune checkpoint inhibitors need to be personalized, especially in combination setting. Who should get LAG3, who should get OX40 and others. And then we will also do personalized therapy. And I think as we move along, we should focus a little bit on the early stage as well, identifying patients at risk and optimizing cure for these patients. Thank you.
Thanks, Govindan. So we'll have Bepi come and talk about